Welcome to this webinar where we will be looking at the concept of low flow anaesthesia. So this is an overview of the webinar. We will discuss the principles of low flow anaesthesia, then the advantages and disadvantages associated with the technique. I will go over the practical aspects of low flow anaesthesia, some of the potential problems to watch out for, and some ideas of flow rates to use in our patients. Finally, in the light of COVID-19, I have some suggestions of ways, in addition to low flow anaesthesia, to reduce our oxygen use. So there are different definitions of what low flow anaesthesia actually is, depending on where you read. Fresh gas flow is the total of our flow rates of gases, which are usually oxygen with or without air. So some people define low flow anaesthesia as a fresh gas flow significantly lower than the minute volume of a patient. Just to remind ourselves, the minute volume is the volume of gas inhaled or exhaled in 1 minute. An easy rule of thumb is 200 mils per kilo. So for a 30 kilogram dog, the minute volume would be 30 times 200, which is 6 litres. So we would aim for significantly less than this. Another definition is that 50% or more of the gases are rebreathed after carbon dioxide absorption. I like the classification of flow suggested by Baxter in the box, which defines medium flow as 1 to 2 litres per minute, low flow as 500 to 1,000 millilitres per minute, minimal flow as 250 to 500 millilitres per minute, and metabolic flow as less than 250 millilitres per minute. It is worth mentioning that this is during the maintenance of anaesthesia, and there will be higher flow rates needed in the initial phase of anaesthesia. So here are some of the advantages of low flow anaesthesia. Firstly, we can better maintain temperature and humidity in our patients' airways, which we will see as highly beneficial. Less oxygen and volatile anaesthetic will also be used, which in a time when we may not have access to oxygen as easily as normal is very important. We have also seen shortages in isoflurane in the past year. Using less gases and anaesthetic agents reduces the financial cost, and low flow anaesthesia importantly reduces workplace and environmental pollution. There are some theoretical disadvantages to low flow anaesthesia, which you just need to be aware of when starting out, and most of these can be avoided quite easily. Firstly, because we are adding much lower quantities of gases which contain oxygen and anaesthetic agent to the breathing system, these will be diluted by any gases in the patient's respiratory tract, and the volume of gas, usually air, already in the breathing system. This means that there is the potential for oxygen to be diluted, and we are delivering less than we think, so a hypoxic gas mixture is a possibility. This is a consideration at the start of anaesthesia and at the end if using nitrous oxide. Also, because of the gas dilution, less anaesthetic gas will be delivered than we think, so it may be more challenging to keep the patients under a stable plane of anaesthesia. And when we need to change depth of anaesthesia, this takes more time because the fresh gas flow rate is so low. So it's a matter of learning how to use the breathing systems in this way. A circle breathing system is used for low flow anaesthesia, and there are disadvantages associated with this. Although low flow anaesthesia can potentially save a huge amount of money, there are equipment costs during the setup, the breathing systems, gas monitoring, and machines capable of accurate low flows. We find ourselves in a situation now with COVID where we need to adapt to using low flow anaesthesia, possibly without all the equipment and monitoring that we would ideally have, so we will address this later. So let's look at how low flow is beneficial to maintain temperature and humidity. Oxygen and air are stored and delivered from cylinders, so the gases are cold and dry. Usually air is humidified by the nose and mouth, but when a patient is intubated, these normal mechanisms are bypassed. So if we do nothing, cold, dry gases are inhaled. The problem with this is that water will move out of the mucus lining the airways to try and humidify the air. This results in viscous mucus, which can obstruct bronchi and the trachea, causing atelectasis and infection. Normally, the mucociliary escalator works to move mucus and debris out of the lower airways to the pharynx. This relies on cilia, which line the airways, moving in a coordinated way. dry air actually destroys the cilia, and so there is a loss of function and mucus and debris are not removed as they should be. Studies have shown that using a fresh gas flow of half a litre a minute maintains temperature and humidity. To illustrate this with clinical data, a study in 2011 enrolled 50 people. They were split into two groups. One had a fresh gas flow rate of 1 litre a minute, and the other group received a fresh gas flow of 3 litres per minute. Hemodynamic parameters, changes in humidity and temperature of the inspired gases were measured. Mucociliary clearance was also measured. In the lower fresh gas flow rate group, respiratory function was better preserved and mucociliary clearance was higher. So using 1 litre a minute compared to 3 litres a minute is better for the trachea and bronchus to function properly. The next advantage of low flow is to reduce our oxygen and volatile anaesthetic usage. We are expecting a massive increase in oxygen use by the NHS in the coming months due to the COVID-19 pandemic. Patients presenting with COVID needing ICU care and needing extended periods of ventilation. The average time seems to be around 16 days, so this will require a huge amount of oxygen. There have already been warnings that hospitals could run short of oxygen in hours rather than days at an Association of Anaesthetists webinar discussing the crisis. BOC have guidance on their website. They have increased their stocks of gases and have asked that customers with medical oxygen ensure that the empty cylinders are available promptly for collection. Only empty cylinders will be exchanged for new ones. I have just put here a reminder of how much oxygen the two commonly used sizes of oxygen cylinders contain. A larger J cylinder contains 6,800 litres and the smaller E cylinder contains 680 litres. We'll bear this in mind later when we work out how much oxygen is used in anaesthetic at different flow rates. So we need to be prepared for reduced oxygen supplies and modify our case management where possible to reduce our use of oxygen and conserve supplies that we have. We will discuss some management strategies in addition to low flow anaesthesia at the end of the presentation. So let's look at the cost reduction with low flow and the reduced use of volatiles. So we will use less volatiles. These are results from a study in people where they were divided into 3 groups with fresh gas flows of 1.5, 3 or 6 litres per minute. You can see the different fresh gas flow groups on the x-axis and the sevoflurane consumption on the y-axis. As we might expect, increasing the fresh gas flow increases the sevoflurane consumption. But what is surprising is that the sevoflurane consumption increase is not linear. It more than doubles with each doubling of the fresh gas flow rate. So going from 3 to 6 litres per minute, the sevoflurane increases from 0.16 to 0.41 millilitres per minute. So this shows what an impact reducing the fresh gas flow rate can have on the isoflurane or sevoflurane usage. In a different study, they implemented a low fresh gas flow policy throughout the hospital department, which meant a maximum of 1 litre per minute was allowed for the maintenance of anaesthesia. When a change in volatile concentration was needed, the fresh gas flow rate was allowed to be increased to 2 to 3 litres per minute and then reduced back down to 1 or less. They calculated the number of anaesthesia hours per bottle of sevoflurane to see how the use was changing. After 5, 10 and 15 weeks, they did calculations to work out the number of hours of anaesthesia they were getting from each bottle of sevoflurane. And after 5 weeks, this had increased by 74% to an extra 17 hours per bottle. With time, the effect did decrease, whether this was down to a change in people slipping back to their old ways, but overall, the number of anaesthesia hours per bottle increased by 38%. So this is a substantial amount when you consider the costs of a bottle of sevoflurane. These prices are from 2019, but they've only slightly changed this year. So it might be useful for you to have the equation to calculate how much isoflurane or sevoflurane you're using. You can calculate it using this equation. So you need to work out the volume of anaesthetic. To work out the volume of anaesthetic agent, you can do this if you know the average or mean fresh gas flow rate for the anaesthetic, the average anaesthetic agent concentration, and the time of the anaesthetic. You plug these into the equation. You also need to know the saturated gas volume. These are listed below. It's 195 mils for isoflurane and 184 mils for sevoflurane. That's the volume of vapour from 1 ml of anaesthetic agent. I've included this slide as a reference for how to do the calculation. So in this example, we've got a 30 kilogram dog having anaesthesia with a circle. So the first 10 minutes, the settings are a fresh gas flow rate of 4 litres and then isoflurane at 2%. And then for the rest of the anaesthetic, 90 minutes, we've reduced down to 2 litres per minute with isoflurane at 1.8%. So first of all, to work out the mean fresh gas flow, it's 4, which is 4 litres per minute for 10 times 10 for 10 minutes, plus 2 times 90, and that comes to 2.2 litres. And then we need to convert it to millilitres for the final equation, so that's 2,200 millilitres. So we calculate the mean isoflurane percentage in a similar way. So that's 10 minutes at 2% plus 90 minutes at 1.8% divided by the total of 100 minutes, and that gives a mean isoflurane of 1.82%. So you can put all the numbers into the equation and it shows that we used 20.5 millilitres of sevoflurane for the anaesthetic. So this table shows some different scenarios for the same dog depending on what anaesthetic agent we're using, and it's just useful for reference. So the purple at the top is isoflurane and the yellow rows are sevoflurane. So for each agent there are 3 different situations. First, using a circle at initial flow of 2 litres per minute and then reducing to 1 litre per minute. And the next is using 4 litres per minute, reducing to 2 litres per minute. And finally, using 6 litres per minute for the entire anaesthetic, as you might need to do with a LAC, a non-rebreathing system, which uses much higher flow rates. So these are all calculated for 100 minutes in total for a 30 kilogram dog. So if you look at the anaesthetic volume used, which is the 6th column along, at the different flow rates, the volumes are roughly double with the higher circle flow rates, but massively higher with a LAC. So this is reflected in the volatile costs. Sevoflurane is much more expensive than isoflurane, and so low flow anaesthesia makes sevoflurane a much more cost-effective option. We'll talk about the environmental effects of the gases later, but the carbon dioxide production is shown in kilograms per hour in the second to last column. Sevoflurane is much better for the environment in terms of greenhouse gas emissions, as you can see by the lower carbon dioxide production. Finally, and most importantly, in this current COVID crisis, I've calculated the overall oxygen use for the different protocols. So bear in mind an E cylinder contains 680 litres of oxygen. You can see how with the first low flow protocol, we'll use 110 litres of oxygen. So one cylinder would last for about 6 dogs. If a LAC is used, we'd get through almost a whole cylinder in one anaesthetic in this dog. So an easier way than manually calculating the use of volatiles is to download this app from the Apple or Play stores. So when you've downloaded it, you first need to tap on the settings icon and you can enter the prices of your anaesthetic agents, and then tap on the tech plenum icon to see, I'll show you in a couple of screens how you can work out what you're using. So this is what comes up when you click on the settings icon. So you can put in how much you pay for your bottle of sevoflurane and isoflurane, so it can work out the costs for you later. So when you go onto the tech plenum icon, it comes up with this screen. And you can use the app. You just put your finger on the settings, on the bobbin or the vaporiser setting, and scroll it along or up or down. So here we've put the settings for a fresh gas flow rate of oxygen at 6 litres per minute, and then I've put the isoflurane at 1.6 and the sevoflurane at 2.5, so you can compare the costs with both of these and the carbon dioxide production. So you can see that isoflurane at that fresh gas flow rate is costing £4 an hour, sevoflurane is costing £42 an hour, but the carbon dioxide production is over double for isoflurane than sevoflurane. The flow rates down to 1 litre per minute with the same vaporiser settings, you can see the costs massively reduce, and so does the carbon dioxide production. So before we look at the potential problems with anaesthetic gases we use, I thought we could go over the basics of the greenhouse gases. So what actually is a greenhouse gas? It's any gas that absorbs heat, keeping the atmosphere warmer than it should be. So the main greenhouse gases in the atmosphere are water vapour, carbon dioxide, methane, nitrous oxide and ozone. The Kyoto Treaty is an international agreement to control the levels of about 7 greenhouse gases, and nitrous oxide is one of the gases on the list. Anaesthetic gases, the volatile ones, are potent greenhouse gases. And in addition, nitrous oxide also causes destruction of the ozone layer. So this diagram shows how solar radiation enters the Earth's atmosphere. So this is essential for life. It then gets emitted back out from the Earth's surface as thermal radiation. Greenhouse gases are a problem because they last in the atmosphere for a long time and they absorb infrared radiation that should be leaving the atmosphere and instead reflect it back to the Earth again. So normally infrared radiation between 8 to 14 micrometers can escape from the atmosphere, but anaesthetic gases are a problem because they absorb wavelengths around 10 micrometers, which causes something called positive radiative forcing, and this causes warming of the planet. The effects of the different greenhouse gases on warming are not the same. It depends partly on how long they last in the atmosphere and how much they absorb and reflect infrared radiation back to the Earth. So to compare the different impacts of the different gases, global warming potential, which is GWP, is used. So this gives an idea of the amount of warming a gas would produce over 100 years. For the scale, carbon dioxide is assigned a global warming potential of 1. So if you look at this, these are some of the Kyoto gases. You can see from the table how much more of an impact nitrous oxide has than carbon dioxide. It has a number of 298 compared to 1 for carbon dioxide. So now moving on to our anaesthetic gases, which I've added to the table. These are the global warming potentials for these. I've highlighted the ones most commonly used in veterinary practice, and you can see how much worse for the environment isoflurane is than sevoflurane. 510 compared to 130. This makes the point that although we don't produce relatively that much volume from anaesthetic gases, they are still really potent greenhouse gases because of the wavelength of infrared radiation they absorb. Nitrous oxide also hangs around in the atmosphere for 110 years. That's the atmospheric lifetime. And because of this, we've stopped using and recommend not using nitrous oxide in veterinary anaesthesia. The Sustainable Development Unit has a report available online called the Carbon Footprint from Anaesthetic Gas Use. So they have calculated the environmental impact of gases used in the healthcare system in the UK. And they identified that anaesthetic gases are potent greenhouse gases. There are some quite surprising findings. 5% of the carbon footprint of what they call acute organisations, so those doing surgery, come from anaesthetic gases. And that's a big figure considering how massive the NHS is and private healthcare service are in the UK. So this is equivalent to half the emissions for heating all the hospital buildings and water. Nitrous oxide use in the healthcare system in the UK makes up 1.3% of the total nitrous oxide emissions in the UK. The report states that desflurane and nitrous oxide are the worst gases and sevoflurane has the least effect. They advise consideration of intravenous anaesthesia and the need to measure, monitor and report our use. For us in veterinary practices, volatile anaesthetic agents will make up a large part of our carbon footprint, and this is something we can easily reduce straight away by using low-flow anaesthesia. These graphs come from the report. The left-hand graph shows the global warming potential for some of the anaesthetic gases, with desflurane, which is commonly used in people, having the biggest effect in the atmosphere. Sevoflurane has the least effect. The right-hand graph shows the estimated total emissions from the NHS in England. You can see nitrous oxide emissions are over 5 times that of any other gas. So less than 5% of inhalational agents are metabolized. Most of the volatiles and anaesthetic agents we use are vented straight back into the atmosphere by scavenging systems. So the less we use and waste, the better. Ways we can reduce our waste are to use low-flow anaesthesia, which we will discuss a lot more detail. We should avoid volatiles with a high environmental impact. As we saw in the earlier slide, desflurane and nitrous oxide are particularly bad for the atmosphere. Sevoflurane is better than isoflurane, though more expensive, but this cost impact can be minimised by using less of the agent by low-flow anaesthesia. Using other drugs at induction or infusions during anaesthesia can reduce how much volatile is needed to keep the patients anaesthetised and in a stable plane of anaesthesia. And regional anaesthesia reduces analgesia and anaesthesia requirements. Lastly, capture and recycling, which is being developed in the UK by SageTech. The idea behind this is to literally collect and capture exhaled sevoflurane and process it so we can use it again. We are hoping this will be rolled out into the veterinary market in the future. An important factor in this is looking at how the volatile is transported to and from the treatment plant, and they are aiming to use NBS to avoid creating any extra carbon footprint. SageTech have just won an award for innovation in anaesthesia, critical care and pain. This product will reduce costs and reduce environmental pollution. So now we will move on to the practicalities of how to use low-flow anaesthesia in our patients. So I appreciate that every practice is different with equipment available, but we will need to use circle breathing systems, either the more traditional styles that we get from Burton's, for example, or the Humphrey ADE. Ideally, we would have capnography with low-flow anaesthesia to help guide the vaporiser settings and also for patient safety, and to ensure there is always sufficient inspired oxygen and not a hypoxic mixture. I'll briefly mention the pharmacology of the volatiles and then the technique. So to be able to use fresh gas flows less than 1 litre a minute, the anaesthetic machine needs to have a scale lower than 1 litre per minute. In this photograph, you can see a separate glass tube to the left with a scale that goes from 0.1 to 1 litres per minute. If your machine doesn't have this, that's fine, but just don't go lower than 1 litre per minute. So remember to read bobbins from the top and balls from the middle, as accuracy becomes really important with low flows. I'll show you examples of gas monitoring and why it's useful and really essential for very low flows. We're interested in the inspired gases, oxygen, carbon dioxide, and the anaesthetic agent. FI denotes inspired. Also expired, carbon dioxide, and anaesthetic agent. So ET denotes end tidal, so expired. Other monitoring is an alarm for low inspired oxygen concentration and pulse oximetry. It's important to ensure there are no leaks in the system, so the patient will need a cuffed endotracheal tube, or it might be possible with a laryngeal mask airway. So I want to show you how the gases get diluted, as we will need to allow for this in how we do our low flow anaesthesia. So when the fresh gas flow rate is less than the minute volume of the patient, the concentration delivered by the anaesthetic machine will be different to that inspired by the patient. So remember, the minute volume is the volume inhaled in a minute. So for a 30 kilogram dog is 6 litres per minute. So in this example, the total fresh gas flow rate is 2 litres per minute, and the isoflurane is set at 1.5%. However, on the monitoring, we can see that the inspired isoflurane is only 1.1% and the end tidal isoflurane is 0.85%. This is lower than we might expect from looking at the vaporiser setting. Here's a few useful definitions that you might just need reminding of. So rebreathing is when the expired gases are rebreathed. Tidal volume is the volume of gas exhaled in one breath, so usually that's 10 to 15 mils per kilo. The minute volume is the volume of gas exhaled in 1 minute, which is normally 200 mils per kilo. So the minute volume is tidal volume times respiratory rate. And the functional residual capacity is the volume of gas in the lungs at the end of expiration. And this is considered because it can add and dilute to what is in the breathing system. So how much oxygen do we actually need? The requirement is 2 to 3 mils per kilo per minute. So a 30 kilogram dog actually only needs 90 mils per minute, and a 100 kilogram dog would need 300 mils per minute. When we look at non-rebreathing anaesthetic machines, we have to use a fresh gas flow high enough to prevent rebreathing. So for a LAC, which is considered efficient, there is a circuit factor of 1. So the fresh gas flow needs to be 1 times the minute volume to prevent rebreathing. With circles, we don't need to prevent rebreathing as there is soda lime to absorb the carbon dioxide, and this is why the flow rates can be so much lower. We do need to allow for capnography sampling. The line will take up to 250 mils per minute from the breathing systems, which at very low flows is significant. So for safety, I would suggest not going below 1 litre per minute if there is no capnography and gas monitoring. With experience, capnography and gas monitoring, an anaesthetic machine is capable of lower flows. Going to 0.5 litres per minute is possible. So here's just a recap of the breathing systems that we use and to remind ourselves what their function is. So we want to be able to deliver oxygen, to remove carbon dioxide, and to deliver the inhalational anaesthetic agent. The classification that we've all learned over the years is divided into open, semi-open, semi-closed, and closed. So whether we use a non-rebreathing or a rebreathing system with carbon dioxide absorption like the circle, we will be using them in the semi-closed function. So just to mention briefly some pharmacology, a steady state of anaesthesia is rarely ever reached in inhalational anaesthesia in our patients, as this takes a long time to stabilise, and our patients aren't usually anaesthetised for long enough. So it's when the concentrations of anaesthetic in the vaporiser, alveolus and blood are all in equilibrium. So uptake of the anaesthetic into the body at the start of anaesthesia depends on several factors: the partial pressure gradient across the alveolus, alveolar ventilation, the blood gas solubility coefficient of the agent, cardiac output, and how soluble the drug is in the central nervous system. This graph shows how the blood gas solubility of the agent affects how quickly it gets taken up and has an effect on the body. The x-axis is time and the y-axis is the ratio of alveolar concentration to inspired concentration. You can see that isoflurane has a high blood gas solubility. It is more soluble in blood, so it takes longer for the alveolar concentration to equilibrate with the inspired concentration. Sevoflurane has a lower solubility in blood and has a much quicker effect. So this makes sevoflurane really useful in low flow anaesthesia to help change the depth of anaesthesia faster. So in low flow, the amount of volatile added to the breathing system is small compared to the overall volume of the breathing system. So any change in depth of anaesthesia will be slow, and we can speed this up by increasing the fresh gas flow rates temporarily and increasing the vaporiser dial setting. Sevoflurane is particularly suited for low flow because of its low blood gas solubility, so its coefficient is 0.69 compared to isoflurane, which is 1.4. Okay, so let's talk a bit about the circle breathing systems. These are pictures of some commonly used ones. So the one on the left is from Burton's and the one on the right is a Humphrey ADE. So a circle has the following components. There's a canister of soda lime. This absorbs the carbon dioxide and has two ports to which the tubing attaches. There are two unidirectional valves, one inspiratory and one expiratory, so that gas can only flow in one direction around the circuit. The tubing can be used in different widths. So this photograph contains a 22mm diameter tubing. The Humphrey ADE uses 15mm smooth bore tubing. There's also a reservoir bag, which should be at least twice the tidal volume, and a Y piece, which you can see at the bottom left. So this is a photograph of the Humphrey ADE showing the APA valve and then the expiratory and inspiratory valves, which are labelled with arrows. One of the requirements to use low flow anaesthesia is to ensure there are no leaks. So there are a few common places where leaks can occur. So the endotracheal tube the cuff may not be inflated enough, or it could be faulty, so the whole tube needs replacing. So be sure to check your cuffs before intubation. Other common places are where the soda lime canister is attached, particularly on the Humphrey ADE, which is at the bottom on the right hand picture there. When the soda lime gets replaced, often they're not fully closed again. So the rebreathing bag may perish, particularly around the top, and there could be holes there. The Y piece can get cracks in it, and the capnograph lines can commonly get holes and snap just at the weak points that are circled in those two photographs. On the Humphrey ADE, other places for leaks are where the canister is not screwed on properly. So checking the breathing system before use is really important. I'll just recap the main steps. Firstly, you should check that the breathing system is assembled correctly. There are no obvious holes or cracks or obstructions. So next, attach the system to the anaesthetic machine and check this is secure. And then we need to check for leaks. So close the APL valve and occlude the patient's end with a finger or a bung. The system should be filled with oxygen to a pressure of 30 to 40 centimetres of water or until the bag looks distended. Check that the bag doesn't deflate. Then switch off the oxygen and check the pressure is maintained for at least 10 seconds or that a flow of no more than 200 mL per minute is needed. So then next, open the APO valve, check that it empties immediately. And then finally, you can check the unidirectional valves by occluding the patient end. Close the APL valve and squeeze the bag a few times, and you should be able to see the valves move. Always at the end of the checks, make sure the APL valve is fully open. So we will be using soda lime in the circle breathing systems. The function of the soda lime is to absorb the carbon dioxide, and it also produces heat. There are different kinds of soda lime. The constituents are mainly calcium hydroxide with strong alkalis to catalyze the reactions. So these have been associated with the formation of compound A and carbon monoxide, and so have been removed or reduced in more modern soda lime. So changes have included adding zeolite, which maintains the pH at a higher level for longer and retains moisture, so improving the carbon dioxide absorption. It also has a lower risk of carbon monoxide and compound A production. So just remember the indicator dye, some of them go pink or red to white, and others go from white to purple. So make sure you know which one you've got. So just so you're aware that there are some unwanted substances that are formed by reactions with soda lime. Compound A is formed by a reaction with sevoflurane and moist soda lime at low fresh gas flow rates, and it's been found to be nephrotoxic in rats, but there's minimal risk in people. Some countries do limit exposure, maybe to 2 hours, for example. Also, carbon monoxide has been formed with dry soda lime and isoflurane, enflurane or desflurane. This was usually a problem when anaesthetic machines were switched off but left with a minimal flow rate of oxygen all weekend. Then the first patient on Monday was exposed to carbon monoxide. So just some of the other disadvantages of circles. The cost, cleaning can be tricky, so use a heat moisture exchanger to minimize any contamination of the breathing system. There's resistance to breathing because there's valves, there's dust, and dead space can increase if the soda lime has a thing called channeling, where the gases can go through channels in the soda lime. So just make sure that the soda lime canister is filled correctly to the right level. We need to make sure that the unidirectional valves are working properly. And then there's also the disadvantage of the unwanted substances such as compound A and carbon monoxide, but in clinical practice these are not significant. So the disadvantages of low flow anaesthesia. Firstly, because we're adding such smaller quantities of gas to the breathing system, there's the potential that these gases will be diluted by any gases already in the patient's respiratory tract and already in the breathing system before we started to use it. So there's the potential for oxygen to be diluted, and we're delivering less gas than we think, so hypoxic gas mixtures. Also, as we're delivering less anaesthetic gas than we think, it can be more challenging to keep the patients under a stable plane of anaesthesia, and when we need to change the depth of anaesthesia, this can take more time. So it's a matter of learning how to use the breathing systems, and these things can be overcome. So we'll go through how to use the circle. I've divided it into 4 stages: the start, which was traditionally called denitrogenation, and the wash-in phase. So we're trying to get the gases we want into the breathing system and remove the ones that are already there and the gases that are in the patient. And then the maintenance phase, where we just want to keep our patient at a stable plane of anaesthesia. And then we need to make some allowance for how we change depth of anaesthesia, because the patient may become lighter than we want. And then the end of anaesthesia, what we do before we wake the patient up. So after induction of anaesthesia, when the patient is first connected to the circle, the flow rate needs to be high for a few minutes to replace all the air in the breathing system and the functional residual capacity, so that's the gas that was already in the lungs of the patient at the end of expiration. So the volume of the breathing system will affect how long this takes. So if you've got a very wide, long tubing, as we do, for example, in our MRI, where we're a long way from the patient, we need a higher flow rate for longer to enable the gas to fill this breathing system. So this table shows the MAC, which stands for minimum alveolar concentration of the inhalational anaesthetic agents sevoflurane and isoflurane. So it refers to the end tidal concentration of volatiles that we would expect to prevent movement to a surgical incision of half of unpremedicated patients, and it's useful just to bear that in mind. So just remember it refers to the end tidal concentration of the gases. So I would suggest using a fresh gas flow rate of around 2 litres per minute for 5 to 10 minutes. So if you're using air, then use at least 1 litre of oxygen. And then I would set the vaporiser setting at 1.5 Mac approximately. So for example, 2 to 2.5% of isoflurane. So this is an example. The fresh gas flow is set at 2 litres per minute of oxygen, and the isoflurane setting is 1.8% in this case, so a bit lower than 1.5 times Mac. So you can see here the end tidal isoflurane is 1.1, so it's approaching Mac in dogs. So here we could think about switching to the next phase of maintenance phase. So here we want to aim to have a fresh gas flow rate of 0.5 to 1 litres per minute. If you've got no capnography or agent monitoring, then I would suggest always maintaining a minimum of 1 litre per minute. If you have an air mixture and you can monitor capnography and inspired oxygen concentration, then the minimum would be at least a minimum of 0.5 litres per minute of oxygen. So you can use agent monitoring to guide the volatile setting. The volatile setting will need to be higher than in high flow anaesthesia. So at a lower fresh gas flow rate, we need to use a higher volatile percentage than we would normally use. It's recommended in people that the end tidal anaesthetic agent is 0.7 to 1.3 times Mac in people. So I would suggest using a flow rate of 0.5 to 1 litre per minute at a Mac of 1 to 1.5 times Mac. So here's an example of a maintenance phase in a patient. We've reduced the fresh gas flow of oxygen to half a litre per minute, and the vaporiser setting is about 2.3%. And this is resulting in an inspired isoflurane concentration of 1.5% and an expired concentration of 1.2%. So what if we need to change the depth of anaesthesia? We could give an inhalational bolus, so increase the vaporiser setting and the fresh gas flow rate for a few minutes. So we could increase up to 1.5 to 2 times Mac, and then the fresh gas flow to 2 litres per minute, depending on the size of the breathing system and the patient. You can dump the reservoir bag contents if required to help refill quicker. Some people advocate increasing the fresh gas flow to 100 mils per kilo per minute, which would be 3 litres for a 30 kilogram dog. But I would judge the fresh gas flow increase based on the patient's size, as the minute volume of the dog does influence how quickly the inhaled volatile concentration will change. And then the final phase is the end of anaesthesia and the washout phase. So I would suggest 100% oxygen at 2 litres per minute for 5 minutes. So here's an example showing the dilution effect in this dog. So we have a 20 kilogram dog. The minute volume is 200 mils per kilo a minute, which is 4 litres per minute. The wash-in phase is 2 litres per minute, and the maintenance phase, the fresh gas flow, is 0.5 litres per minute. So here, the dilution effect, the minute volume to fresh gas flow ratio in the wash-in phase is 2 to 1, but as soon as we drop the fresh gas flow rate to half litre a minute, you can see how the minute volume is diluting the fresh gas flow by 8 to 1. And this is why we need to keep our isoflurane or sevoflurane vaporiser setting high. Just to mention a closed circle system. This isn't done in veterinary clinical practice. You'd need to supply the oxygen requirement at 2 to 3 mils per kilo a minute. It would absolutely be essential to monitor anaesthetic and oxygen agent monitoring. The fresh gas flow is low, so the inspired concentration is very different to the vaporiser. And gas leaks, agent uptake into tissues is very significant, and it takes hours to reach a steady state. And obviously the capnography volume that's removed, it would be very significant. So this isn't done in veterinary practice, and I wouldn't recommend it. Just also to mention nitrous oxide, you need to be aware of the risk of hypoxic mixtures. Oxygen is taken up into the body, so the oxygen concentration in the circle will decrease over time. Nitrous oxide is not taken up into the body, so nitrous oxide concentration in the circle would increase. So monitoring of inspired oxygen is needed. Where there's no monitoring, never go below 50% of oxygen inspired, and the flow rate of oxygen needs to be over 20 mils per kilo per minute. But we would advise avoiding nitrous oxide due to the environmental effects. So what about low flow anaesthesia in cats and small dogs, where we possibly can't use a circle? So the options in cats are to use the Humphrey ADE, if you have one, so use without the soda lime canister, and this is a very efficient breathing system, so fresh gas flow rates of 70 to 100 mils per kilo per minute are needed. Also, there's the option for mini lacs if they're available, but be careful with the sticky APL valves that can sometimes get stuck. In small dogs, we need to consider the breed, the condition score of the patients. So if they're overweight and 10 kilograms, this might be very different to a very lean dog that's 8 kilograms, for example. And also capnography can help guide which breathing system to use if you have it, because it will show if the animal is hyperventilating or not. So Humphrey ADE is recommended in small dogs less than 7 kilograms to use without the soda lime canister, but over 7 kilograms you can use with the soda lime canister. If you don't have a Humphrey ADE and normal circles, in the smaller dogs you could consider using narrow, smooth internal bored tubing at 15 millimeters in smaller dogs compared to the normal 22 millimeter diameter tubing. So we've discussed low flow anaesthesia. I've just got a couple of slides talking about how we can overall reduce our oxygen use in the practice at the moment. So first of all, we want to minimise the time under anaesthesia. So consider, is anaesthesia really needed in this patient? Also, can we divide the anaesthesia and make it shorter by giving a sedation for any diagnostic work that doesn't need to be done under anaesthesia, for example, x-rays or a CT scan? And this then may reduce how much oxygen we need and the length of time of anaesthesia for surgery. It's really important to optimise our efficiency and workflow to minimise the time of anaesthesia. So be as prepared as possible, getting everything ready, checking everything before the animal is anaesthetised. And make sure there's enough staff to help to prepare for theatre. Obviously, it's very difficult at the moment. We need to maintain social distancing, which I think means that being prepared equipment-wise as much as possible before anaesthesia is so important. And also make sure the surgeon is ready in theatre to open kits and start surgery with no delay that will prolong the anaesthesia. So the other way we can reduce oxygen use is to use lower flow rates of oxygen. So things to consider are pre-oxygenation. It's really only effective when you pre-oxygenate with a face mask for 3 minutes. Sometimes we waste a lot of oxygen by doing flow-by that's not really having any benefit to the animal. So just be aware of this and try to minimise the use of flow-by unless it's really essential or it's being done effectively with a face mask. So switch the oxygen on only with an anaesthetic machine when the breathing system is attached to the patient. Sometimes people will switch on the oxygen in advance before anaesthetising the animal. This also risks workplace pollution of anaesthetic agent that's in the breathing system. Another way is to consider using extra drugs. For example, alpha-2 agonists like medetomidine can be very beneficial if included into the pre-medication or used as continuous rate infusions during anaesthesia, particularly in cats. These can help provide a more stable plane of anaesthesia and perhaps reduce the volatile requirements and any incidences of becoming into a more light plane of anaesthesia during surgery. Other drugs that can be used as infusions during anaesthesia include ketamine, lidocaine, but not in cats, and fentanyl. The infusion rates are shown here for reference. Also consider if regional anaesthesia can be used in your patient. Nerve blocks, for example, for any orthopaedic surgery or dental surgery are very beneficial. Include air in the fresh gases where you can, but be aware of hypoxic gas mixtures. So use at least 50% oxygen in the fresh gases and monitor the inspired oxygen. And that was essential if you're going less than 1 litre per minute of oxygen. If you have ventilators in your practice, most of these are powered by oxygen, so a minimal use of ventilators will help reduce oxygen use. So turn the anaesthetic machine off after the patient is disconnected if your machine has a minimum flow that is always going through the machine, and that will reduce some waste. Some of the breathing systems, like the T-pieces, come with red stoppers at the end, the patient end of the breathing system. So if you have those, you could put those on the end of the breathing system when they're not in use. And this will also reduce pollution of the workplace. So reduce fresh gas flows as low as possible in non-rebreathing systems. This will be possible if you have capnography and you can monitor for rebreathing on the end tidal carbon dioxide levels. And also using low flow anaesthesia for circle breathing systems. So in conclusion, there are lots of benefits to low flow anaesthesia, and these outweigh the risks if we know what we're doing and are careful. So there is urgency to minimise environmental pollution, and low flow anaesthesia is something we can all do quite quickly. So sevoflurane is the least harmful volatile for the environment. We should be avoiding nitrous oxide, there's not enough benefit. And using low flow makes sevoflurane much more cost effective. So there'll be some investment in equipment and training needed, but overall the cost should be worthwhile. And then we need to be aware that supplies of oxygen may be limited during the COVID-19 crisis, so consider all workflow methods to reduce the oxygen use. Here's some reading and references if you're interested in any further reading. And if you have any questions, feel free to email me. Thank you for listening.